Hey everyone, Dr. Anthony Kaveh here. In one of the most mysterious places in the world, the operating room. Let's face it, there is nowhere else, no other bed you can possibly sleep on, no room you can be in connected to a ventilator like here, no room you can come into and have your memories wiped in some of the most vulnerable moments of your life. And no one ever talks about the mindset you need to have before surgery so that you have the safest and most comfortable experience in this really artificial sci-fi adventure world, literally, where surgery happens. So here are the top elements of the best mindset you can have before surgery. We're going to jump right into it. It involves three components. Number one is cognitive flexibility. Number two is the tolerance of ambiguity. And number three is the I type of curiosity. That is all of it in a nutshell. We're going to have a live Q&A at the end because I need to break down each of these three for you. And it's really, really, really important to know something that doctors never tell their patients. I don't know why patients never hear this, but the disease that you have when you walk into this room doesn't necessarily impact your surgery outcome as much as you might think. Oftentimes, it's the mindset that you're bringing in that will impact the outcome of your surgery, especially if your surgery is aiming to reduce chronic pain somewhere. Knee pain, shoulder pain, hand pain, wrist pain, abdominal pain, etc. The classics are the gallbladder, the uterus, the appendix. Of course, there's many other examples as well, but it is incredibly important to recognize that number one, the cognitive flexibility that you can bring into this room is huge. That's the first part of the most powerful mindset. And that's in stark contrast to the broken brain. I call the broken brain what a rigid brain experiences when it snaps. Your brain really only does two things when your expectations don't match reality. It can be stuck in a loop, which is really common here in the operating room, or it can literally just freeze in place, or sometimes it can freeze so much that it passes out. I have seen all of these. This is what the broken brain does. This is different than a brain that has cognitive flexibility. So what does the stuck in loops look like? It's when patients come in here, literally they are walking in or being wheeled into this room and they're just repeating on repeat. Oh my God, oh my God, oh my God. Am I going to be awake? Am I going to be awake? Don't let me be awake. I don't want to feel anything. I don't want to feel anything. I'm not making fun of any of them because when you're coming in, I get it. It is super, super stressful. Got all the weird monitors, weird medications, hopefully not weird staff in the operating room. I'm not making fun of them, but I'm just sharing that repeat loop that we get stuck in. Or sometimes the mask, they get really afraid of the mask. I don't want that mask on me. I don't want to feel anything. These are some of the examples of the repeat loops. Now, the passing out actually happened to me earlier today. They see a needle. They get so overwhelmed by an influx of information because, hey, this is a bizarre place that you've probably never been in before. Remember, I see this almost every day, but my patients may see this once or twice in their whole lifetime. So it's overwhelming. I get it. So yeah, I had someone pass out literally earlier today. That's okay. I'm not making fun of them. But recognize that the brain snapping, literally it's like breaking, is very different than a flexibility that allows for something like, I wasn't expecting to remember this or be awake to walk into the room. But like, shoot, what is this bag for over here? It's still in the bag, actually. The bag is in the bag. What is all this equipment for? What is this jelly donut made of? These are all questions that people have asked me before, by the way. They're like, how many light bulbs fit in the light there? Why do you do what you do? That's a really common one. They ask me why I'm an anesthesiologist, like right before they go to sleep. That's super different. That actually leads to one of the other, we'll get to it in a second, the curiosity of interest. So I wasn't expecting to be awake for this, but tell me about this, tell me about that. Totally different than just snapping and having that broken brain that goes into repeat or passes out. Number two is the tolerance of ambiguity. By the way, a comment here, if anyone, you guys leave a comment if you've experienced any of these before. You guys have great comments. I love hearing your experiences. The music relaxing someone is super popular. That's why we like to play music. You can actually request your favorite playlist to play on the speakers as you fall asleep. I think that's awesome. You should totally do it. And ketamine versus ECT, we can talk about that at the end. All right, back to number 2, which was the tolerance of ambiguity. So this is also called the tolerance of uncertainty. We lose our tolerance of uncertainty when we are in survival mode. Partly because tolerating ambiguity means that we're okay with failing. That's really deep, and that's a whole discussion in and of itself, the fear of failure. But we got to recognize that when we're in this totally unknown environment, we are not in our comfort zone. We are not in what I call the control zone, because we don't have control of anything. The second the propofol goes in you, you're giving up total control of your body to your anesthesiologist, right? Tremendous amount of trust. And when we get put to the edges of our control zone, if we are afraid of what's going to be on the other side, which is a natural response when you're in survival mode, then it's very easy to have a catastrophic response to the perceived failures. That catastrophic response can lead to all sorts of consequences down the line, to transition of acute to chronic pain, kinesiophobia that can lead to infections or blood clots, to frozen joints. It's like a jack-in-the-box that is just one crank away from exploding. So sometimes patients are so rigid because they have such little tolerance of the ambiguity, of the uncertainty of this operating room. They're just one level away from completely exploding and breaking. The tolerance of ambiguity is necessary in surgery because it's filled with unknowns. And like I said, breaking down has short-term consequences like passing out, having a panic attack, emergent delirium, needing more anesthesia, so you get more side effects from the anesthesia, with the short and long-term consequences. So far we said cognitive flexibility, which by the way is why every culture in the world has some proverb of the willow reed, which is flexible and sways back and forth in the storm, versus the oak tree, which is this tall, rigid, strong tree, but its branches snap because they don't have that flexibility. So tolerance of ambiguity, cognitive flexibility. Before we go to number 3, just a quick reminder that if you're learning something new, please hit that like button and share what you've learned with others. If you or a loved one is having surgery, please take these tips to heart. Discuss with your doctor so that you don't have to have that breakdown, so that you do optimize your chances for the best healing after surgery, the least amount of pain, hopefully. And as always, you can come to my clinic in San Francisco where we address the subconscious of where all of these live. Anyways, all the links are below. And by the way, I should say, if you want to join our private Zoom meetings, that link is below as well, part of our exclusive access group. So number 3 is the curiosity, specifically of I type, interest type. So curiosity can be destructive or expansive. If it's a need-to-know basis of curiosity, like taking the tests and you don't know the answers and you can't move on to the next answer, the next question on your test, those are need-to-know basis types of curiosity. It's like you're stuck, you can't get satisfied to get the right answer, and there's only one right answer. That's like I call a deprivational or a destructive type of curiosity. That is very rigid, and there's a lot of fear, because if the right answer is not obtained, one is in freak out mode. Totally different than the open-ended, let me see where it takes me. If I go down this Wikipedia article search, type of the curiosity of interest or inspiration. It's inherently expansive. And why is the expansive mindset important? Because it helps expand the playing field. It enriches our perspective. And when we are stuck, especially in anxiety and depression, which by the way, can absolutely be influenced by what happens to your brain under anesthesia when you're having surgery. Typically, the anxiety and depression is of inward focus. Tell me in the comments, right? As we're live here, do you guys all know what I'm talking about? We tend to have an inwardly focused rumination and perseveration when we are in those stuck modes, when our brain is about to break, when we're not tolerant of ambiguity. Joy, I'm doing well, thank you. And Denise, thanks for the kind comments. I want to see someone here live mention what major anxiety is, what Julie Abbott says. Yes, we get inwardly focused. Yep, Gabrielle says the same thing here. How about dental surgery? This applies to nearly all types of surgery, whether you're having open heart surgery or a knee surgery. Our mindset plays a role, not only in how much anesthesia we need, but also what we're going to feel like tomorrow. Loretta has a question about wisdom teeth. We can talk about that at the end. Hold on to that. And Linda is also agreeing that sometimes we still feel that inward focus even after surgery is over. So the point is that curiosity can bring an expansion, like we said, enriching the perspective, expanding the playing field. We're not always at the center of it, which is not a bad thing. Sometimes we get overly stuck when we are the center of attention. Awe and inspiration are critical here, and there is so much to be in awe of in these unknown environments if you have that curiosity of interest cultivated within you. It's not about looking for miracles everywhere. It's about saying, like, what does anesthesia feel like? What is this mask going to smell like? What flavor do you have in there for me, doctor? Like I said earlier, why do you do this? Why are you an anesthesiologist? These are questions that enrich our perspective and help suck us out of some of the stuckness that the broken brain, when it snapped, can fall into. And if this is commiserate, or if this resonates, I'm so curious to see your comments, because I know hundreds of my patients have felt this way, and you're not alone. So number 1 and 2 and 3 that I mentioned here, they put together this powerful mindset of resilience, which means thriving in the face of adversity. And heck, in this room, there is more adversity than any other room I've been in the world. Patients in pain and vulnerability, in suffering. It's not easy. I'm not saying it's a cakewalk, but I'm saying that you can bring in a mindset. If you can combine these 3 things, I have never had a patient not benefit from putting together this resilience mindset with these 3 building blocks. I will say the runner-ups are going to be gratitude and patience. Those are harder to cultivate if you don't have the resilience already growing in your garden of pre-surgery mindset. With that said, I want to jump into the live comments here and answer a couple of your questions. If you're learning something, do please hit that like button and share what you've learned with others, especially if they're having surgery anytime soon. I want to make sure that in this vulnerable, scary setting, you are better equipped to advocate for yourself and feel empowered to speak up for yourself. So we have a question from Danny. Thank you for the super thanks. Had 6 surgeries and never remember extubating, having another on Monday and want to try. Bad idea. Well, Danny, I'm wishing you the best for your surgery on Monday. We typically don't want someone to remember the breathing tube, which, by the way, by example here, we have a whole bunch of breathing. These are the blades that go into the mouth. These are the handles with light sources on them. Here's an example of that breathing tube that she mentioned. You typically don't want to remember this coming out of your mouth. Whoa. So I wouldn't recommend trying to be awake for that. It can kind of be unpleasant. In fact, it's one of the key sources of anesthesia awareness. So I'm hoping you have a successful surgery like the first 6, assuming they were successful. Thank you again for the super thanks. Wendy, I've had double knee replacements. I wish I'd known how much help I needed to deal with my fear and loneliness before. I'm sorry that you had that experience, but I'm grateful that you're recognizing this now, and hopefully you can pass this on to someone else who's going to have knee replacements. Angie is asking very, very, thank you. Denise, I've got to be confident in my anesthesiologist because of cervical instability. Yes, you have to be confident in your anesthesiologist because cervical instability can be disastrous if they don't know about it. And Donna, good to see you. I had surgery last month. Glad I didn't remember anything until I got to my room. Teresa is having gallbladder surgery next week. Wow, I can't click on the right button. I still have yet to not have a panic attack. It does not matter what I do. Teresa, did you know that a certain amount of anxiety is actually helpful? It's a U-shaped curve. A certain amount is healthy. Too little or too much might not be healthy. I'm not saying panic attacks are healthy, but I'm saying that having a goal of 0 anxiety is probably not productive. And I hope that you speak with your other doctors about strategies to help minimize. your anxiety before surgery. Wishing you the best. I hope everyone here sends you positive energy and healing energy. Gabby, I agree. I have seen someone extubated. Oh, extubated. It's not pleasant. I agree. Bushy, transmuting pain into an intense sensation in place of a cessation of. Wow, bushy-haired stranger. It's a very deep comment you're saying, and you're not wrong. But it does take the right mindset to be able to engage with that transformation of the perception of pain. It's a huge topic, hugely interesting topic. And you're so welcome. And chasing the wind. Wow, that's very kind of you. Thank you so much. Heidi is right about propofol burning. The milk of amnesia, as we say, off-label use of using lidocaine with it to minimize the burning can be very helpful, but that's, of course, up to your doctor. You need to explain it with them. How do you prepare for surgery when you are awake? All the more important, because the more your mindset is able to embrace that resilience with those three little subcomponents, the less anesthesia you'll probably need and the more comfortable you'll be while you're still awake. So it's actually more important the less anesthesia you're getting. Isn't that interesting? Ask me about that more if it wasn't clear. Yeah, you're so welcome, Boja. The vent tube size is easily figured out by using the patient's little finger. So that's right. If you have a child, you don't know what size breathing tube to use, you look at their pinky. This approximates the diameter of their trachea. So that's a quick thing to do if you don't know their height and weight. I wonder how you knew that. I'm having a shoulder replacement surgery. I'm always afraid of surgery because I have been accused of just wanting surgery for attention. That's not so. Rachel, I'm sorry that sounds like they've been thinking you have a secondary gain or a malingering type of view. I'm sorry about that. I hope that you are empowered to speak up for yourself about perhaps why that's not the case. Recognizing that at the end of the day, one should not determine their self-worth based on the perceptions of others. Less anesthesia is better. L. Phillips, the right amount of anesthesia is the best amount. Not too little, not too much, because there's side effects in each direction. Todd had a stroke in December. Should I be more concerned than normal? Well, you should always tell your anesthesiologist because there is absolutely a risk of repeat strokes under anesthesia if a stroke is fresh. What's this say? Like making a fist stimulates the size of your heart. That's a good approximation, yeah. 2 fists is almost like the size of your brain, roughly. Hey, if you guys are learning something, once again, please hit that like button and share what you learned with others to empower them in our broken healthcare system better advocate for themselves. If you do want more access to these types of Q&As, you can join our private Zoom meetings. The link is below. It's a great way to support me so I can do this more often for you. People are terrible sometimes, says Violet. They are. I'm not too sure. I hope you're not accusing me of being one of them. Hope not. I spent a month, says Gabby, in surgical tech school and have observed the surgery. That's awesome to hear. Julie says, how does insulin resistance affect surgery? Insulin resistance can lead to hyperglycemia. Now, insulin resistance is normal to an extent, especially because of certain medications that we give, like dexamethasone over here. This steroid, oh, you can't see it. Dexamethasone can absolutely increase your insulin resistance in addition to the stress of surgery. If you're hyperglycemic for too long, that can cause all sorts of problems, including an increase in surgical site risk and diabetic ketoacidosis, or just having a massive drop in your blood pressure, which can be lethal under anesthesia. These are extremes, unlikely to happen, but typically we will cover you with insulin, short-acting insulin during surgery if needed. And oh wow, so many kind comments. Blissful Essence, very nice. And Mel J, I hope that you're also learning something new to advocate for yourself. So many great questions. Oh, a cardiac ablation. I insist on GA. You can't do that. Does anyone know why you can't necessarily get general anesthesia in certain ablations? This is a really interesting question. If you're under general anesthesia, whether it's with this or with the gases, like out of the ventilator behind me, you'll actually turn off some of the pathways in your heart that the cardiologists are trying to ablate. If they can't identify those pathways that they're trying to burn because you're under general anesthesia, they can't effectively burn them off, right? So it's one of the many reasons why sometimes we need to have a mindset that will allow us to undergo a surgery with minimal anesthesia, because there ain't other alternatives to it. Hey, Mallard the Duck, thank you so much for that kind comment. I'm sorry about what you've been through, but I hope that you've been able to apply your passion to something else meaningful. Let's do one last question. This is a good one. Do gases smell like gross plastic, or is that from the mask? Yes, typically they come from the mask. It's like a beach ball. I mean, how can you blame it? It's like packaged in all this plastic here. And then the anesthetics themselves, sevoflurane, let's see if we can reach all the way. Sevoflurane, which is this yellow one here, tends to have what's called a sweet smell. I always would remember it in residency because sevo starts with an S, like sweet. Desflurane, which is not even on this ventilator because, quite frankly, it's very expensive and is a very, very potent greenhouse gas, can actually be irritating to the point of maybe even causing an asthma reaction in some susceptible individuals. So we don't use that one, especially in inhalational inductions. I'm happy that Mila likes the taste of it because they can taste a little bit yummy, yucky, sweet or not. Any preparation for hip replacement surgery, everything we're talking about, Melissa, right now is key for the right mindset to help optimize the chances of you having a successful surgery and one that reduces your pain. So with that said, if you all learned something, please hit that like button and share with others. And we'll end with what Heidi said about dinosaur farts. It's how I describe it to pediatrics, like little kids, when they're putting the mask on, so that we can engage some humor, some curiosity. Oh, I've never smelled dinosaur farts. What do they taste like? What do they smell like? That's a type of mindset. You know, kids can do this very well. When we become adults, we lose these key parts of that surgery mindset, of that optimal surgery mindset, because adults inherently become rigid. Adults inherently lose the awe from learning new things because we think we've learned it all. Kids don't have that. And it's very valuable to look at kids. It's not by accident that kids can be hypnotized so much more easily for less pain. Yeah, right, because when you can guide someone through guided imagery, you can reduce their pain on the order of several milligrams of morphine, actually. Hey, Patricia, thank you for that kind super thanks. So I hope you all learned something new to advocate. Till next time.